Case presentation and discussion. Locked-in syndrome. This presentation focuses on locked-in syndrome, a rare and severe neurological condition characterized by complete paralysis of voluntary muscles in all parts of the body except those controlling eye movement. Patients with locked-in syndrome are fully conscious and cognitively intact, but they cannot speak or move due to the paralysis of nearly all motor functions. This condition often arises from damage to the ventral pons, most commonly due to ischemic stroke from basilar artery occlusion. The case depicted here illustrates the challenges faced by patients with locked-in syndrome, including dependence on ventilatory support and the need for specialized monitoring and care. While locked-in syndrome profoundly affects a patient's physical abilities, communication with healthcare providers is typically possible through vertical eye movements or blinks, which becomes a crucial element in maintaining a connection to the outside world. Throughout this discussion, we will explore the underlying causes, diagnostic approaches, clinical features, and management strategies for locked-in syndrome. We'll also address the role of assistive technologies in enabling communication for patients with locked-in syndrome, which significantly enhances their quality of life despite their physical limitations. This case highlights the importance of a multidisciplinary approach in neurocritical care, emphasizing both medical management and the compassionate support necessary to meet the unique needs of patients with locked-in syndrome. The patient is a 65-year-old man with a history of hypertension, atrial fibrillation, and smoking, which are significant risk factors for cardiovascular and cerebrovascular diseases, including ischemic stroke. Presentation. The patient experienced a sudden onset of complete body paralysis consistent with the characteristics of locked-in syndrome. This condition is typically caused by damage to the ventral pons, where motor pathways, including the corticospinal and corticobulbar tracts, are located. Despite the paralysis, the patient remains fully conscious and able to follow commands using only vertical eye movements. This preservation of consciousness, combined with the inability to move or speak, is a hallmark feature of locked-in syndrome. Limited vertical eye movements are the primary method the patient can use to interact with others. This is an important diagnostic feature that distinguishes locked-in syndrome from other disorders of consciousness where patients may lack awareness or purposeful eye movement. Narrative clinical findings. This slide outlines the key clinical findings in a patient diagnosed with locked-in syndrome, providing a comprehensive view of their physical and cognitive state. Motor function. The patient is quadriplegic, meaning that there is complete paralysis of all four limbs due to disruption of motor pathways in the brainstem, specifically in the ventral pons, which affects voluntary movement. Speech. The patient is anarthric, meaning that they are unable to produce speech sounds because of paralysis of the muscles required for articulation. This is a characteristic symptom of locked-in syndrome, as patients lose the ability to control their vocal cords. Swallowing. Swallowing is absent, necessitating feeding support through alternative means such as a nasogastric tube or gastrostomy. The loss of swallowing function is common in locked-in syndrome as the brainstem damage affects cranial nerves involved in the swallowing process. Eye movements. Eye movements are limited, but critical for communication. In locked-in syndrome, vertical eye movements and blinking are typically preserved, enabling the patient to communicate by moving their eyes or blinking in response to yes or no questions. Sensation. The patient has intact sensory responses to painful stimuli, indicating that sensory pathways are preserved. This allows the patient to feel sensations even though they are unable to move or speak, which is an important distinction from other neurological conditions that affect sensation. Consciousness. The patient is fully alert and aware, which is a defining feature of locked-in syndrome. Despite being unable to move or speak, they are responsive to yes or no questions through eye blinking, allowing them to communicate and demonstrate their awareness of their surroundings. These clinical findings highlight the unique nature of locked-in syndrome. The patient's cognitive and sensory functions remain intact, yet they are trapped in a body that cannot respond voluntarily. The preserved eye movements offer a critical means of communication, enabling a basic level of interaction with caregivers and family, which is essential for emotional support and quality of life. This constellation of findings, paralysis, preserved sensation, and awareness, is central to diagnosing and understanding the challenges faced by patients with locked-in syndrome. Imaging and workup. This slide outlines the key imaging and diagnostic workup findings that confirm a diagnosis of locked-in syndrome secondary to ischemic stroke caused by basilar artery occlusion. MRI. Magnetic resonance imaging reveals an acute infarction in the ventral pons. This location is critical as damage to the corticospinal and corticobulbar tracts in this region leads to the characteristic quadriplegia and paralysis of voluntary movements in locked-in syndrome, sparing only vertical eye movement and sometimes blinking. MRA. Magnetic resonance angiography shows occlusion of the basilar artery. This occlusion is a primary cause of ischemia in the brainstem, particularly affecting the pons. The basilar artery supplies blood to critical regions in the brainstem, and its occlusion often results in significant neurological deficits, including locked-in syndrome. EEG. Electroencephalography is used here to assess the patient's level of consciousness. In locked-in syndrome, EEG findings confirm that the patient is awake and alert with normal cortical activity. This is a crucial distinction, as patients with locked-in syndrome remain fully aware of their surroundings despite their inability to move or communicate verbally. Evoked potentials. Evoked potential testing is performed to assess the integrity of sensory pathways. Intact sensory evoked potentials indicate that sensory pathways are functioning, allowing patients to experience sensations even though they cannot respond physically. This helps in confirming that the syndrome is purely motor in nature with preserved sensory perception. Diagnosis. The combination of these findings supports the diagnosis of locked-in syndrome, specifically secondary to ischemic stroke from basilar artery occlusion. The infarction in the ventral pons disrupts motor pathways without affecting higher cognitive functions, leading to a state of paralysis with preserved consciousness. The imaging and electrophysiological workup are critical, not only for confirming the diagnosis, but also for ruling out other conditions that may mimic locked-in syndrome, such as severe brainstem injury or progressive neurological disease. These diagnostic insights are essential in guiding the management approach and in addressing the unique challenges of communication and care for patients with locked-in syndrome. This slide outlines the key components of managing locked-in syndrome, focusing on acute interventions, supportive care, and facilitated communication. Acute interventions. Administration of TPA. In cases where locked-in syndrome is caused by an ischemic stroke due to basilar artery occlusion, timely administration of tissue plasminogen activator, TPA, can be critical. If given within the appropriate therapeutic window, TPA can help dissolve the clot and restore blood flow to the brainstem, potentially limiting the extent of damage. Mechanical thrombectomy. For patients with basilar artery occlusion, mechanical thrombectomy is another option, especially if they are outside the time window for TPA. This endovascular procedure physically removes the clot, aiming to quickly restore blood flow and reduce the impact on brainstem functions. Thrombectomy is often reserved for more severe cases and requires careful consideration by the neurovascular team. Supportive care. Respiratory support. Given the high likelihood of respiratory failure due to paralysis of voluntary muscles, respiratory support through intubation and mechanical ventilation is often necessary. This ensures adequate oxygenation and reduces the risk of respiratory complications. Nutritional support. Due to the inability to swallow, patients require nutritional support through a nasogastric tube or, in the longer term, a gastrostomy tube. This helps maintain caloric intake and prevents malnutrition. Preventive care. Patients with locked-in syndrome are at high risk for complications related to immobility, such as skin breakdown, muscle atrophy, and joint contractures. Preventive measures include regular skin assessments, passive range of motion exercises, and repositioning to avoid pressure sores. Facilitated communication. Eye blinking for yes or no responses. One of the hallmarks of locked-in syndrome is the preservation of eye movement, particularly vertical gaze and blinking. These movements are often the only voluntary motions left intact, allowing patients to communicate. Eye blinking is commonly used to convey yes or no responses, establishing a basic method for patients to interact with caregivers and medical staff. Eye tracking devices. For more advanced communication, eye tracking devices can enable patients to spell out words or select options on a computer screen. These devices greatly enhance the quality of life by allowing patients to communicate more effectively, make decisions, and participate in their care. Eye tracking technology represents a significant advancement in the management of patients with locked-in syndrome. This comprehensive management approach addresses both the immediate medical needs of patients and their long-term quality of life, emphasizing the importance of early intervention, sustained supportive care, and adaptive communication tools. Through these measures, we aim to provide patients with locked-in syndrome the best possible outcomes and improve their ability to interact with their surroundings. Locked-in syndrome course over weeks. Over the weeks, the patient remains fully conscious but quadriplegic, unable to move any voluntary muscles. This includes both upper and lower limbs. The patient also develops persistent anarthria, which is the inability to speak due to paralysis of the muscles involved in speech. This is a common feature of locked-in syndrome due to the loss of control over the vocal cords and articulatory muscles. Effective communication through eye movements. Despite the severe motor impairment, the patient is able to communicate effectively using eye movements, typically through a yes-no response system based on eye blinking or tracking. This method provides a crucial link to the outside world, allowing the patient to interact with healthcare providers and family members. Long-term rehabilitation planned with supportive care. As the patient's condition stabilizes, long-term rehabilitation is planned, focusing on supportive care. This will include the management of respiratory function, nutritional support, and measures to prevent complications associated with immobility, such as pressure ulcers and contractures. Rehabilitation efforts will also involve maximizing the patient's use of eye tracking devices and other assistive technologies for communication, as well as working to improve overall quality of life. This case exemplifies the challenges of managing locked-in syndrome, where immediate medical care and ongoing rehabilitation are essential for optimizing the patient's functional abilities and ensuring they receive the appropriate physical and emotional support.